Welcome again to 10 Minutes with Harry. Today's topic is a reasonably common situation, but very poorly understood, and the term vagal hypertonia is not really known by many people. Let us have a look at this ECG. Those who look at ECGs frequently will tell you straight away that this is a Wenckebach AV block sequence. The PR interval is gradually increasing, and the first beat after the 2.5 second pause is the normal PR interval. So this looks like a perfect Wenckebach AV sequence, but note that there is no P wave here. This is in fact Wenckebach AV block and sinus arrest. The two are actually fairly common in the young person. We need to revise what we understand about Wenckebach block before we go on. So Wenckebach, or Mobitz type 1, is a progressive lengthening of a PR interval with a drop beat. It's predominantly in the AV node and has a narrow QRS, whereas Mobitz type 2 is where the PR interval remains constant with drop beats, and it is in the distal conducting system. To go over the ECG footprints of Wenckebach sequence, again, we can see the 3 QRS complexes, and there is prolongation, a gradual progressive prolongation of a PR interval, which I call AV node fatigue. Then there is a non-conducted P wave, which is due to AV node block. And then the first beat is a short PR interval where the AV node rests and conduction returns. The sequence patterns of Wenckebach AV block may be 4 to 3, as can be seen on the top left-hand corner. That means that there are 4 P waves for every 3 R waves in a sequence. Therefore, 3 to 2 means that there are 3 P waves and 2 QRSs, and 2 to 1 is 2 P waves to 1 QRS. We can have higher degrees of block, as shown here with a 3 to 1 AV block. One of the important things that we need to understand about Wenckebach sequence is the absolute defining footprint. This is because there are a huge number of different types of ECG presentations of a Wenckebach sequence, and these are all we call atypical. But there's one absolute defining footprint, and that is the PR interval is longest immediately before the drop beat. There is a non-conducted P wave, and the PR interval is shortest immediately after the drop beat. This is the absolute defining footprint. The clinical spectrum of Wenckebach AV block is the young patient with nocturnal Wenckebach, and during the day, the PR interval is normal. This is a vagal phenomenon. This is the vagus nerve at night slowing the heart rate down and having a nocturnal Wenckebach. The older patient is Wenckebach can occur anytime, but there is always first degree AV block. And this is not necessarily physiologic, but rather there is organic disease there in the conducting system. They are probably very different. Type 1 Wenckebach second degree AV block, 15% are typical, and 85%, most of the ones we see, are atypical. So now let us return to that ECG which we saw earlier with the pause, and we see sinus slowing, which is very common overnight. We have a Wenckebach AV sequence there where the PR interval gradually increasing. There is a drop P wave, and then the PR interval again is shortest. You can see that the P to P intervals are shortening as this goes on. And this is what happens overnight, where you get sinus bradycardia as well as Wenckebach sequences. This can be quite severe, as you can see here. One can see that there is a bradycardia, a Wenckebach sequence. There is the dropped beat there. But what is interesting, as you can see with the yellow highlight, is now the PR interval is longer. This is violation of the absolute footprint that I showed you before. And why is that? Well, probably the QRS that follows the prolonged PR interval is probably in a junctional escape beat. And we can see another example of that here with a Wenckebach sequence, and rather than have a short PR interval, the sinus P wave is buried in the junctional escape beat. Here is another example of a heart rate overnight to about 150 beats per minute, slowing dramatically, having a Wenckebach sequence, and once again, the PR interval is prolonged after the pause, and as a result of that, we question this and ask, is this in fact a Wenckebach AV block? I regard this as yes, despite the fact that it violates that absolute principle or footprint that I discussed earlier. So looking at all this, we come to the conclusion that there is something going on with the vagus nerve, and that it is causing both a bradycardia as well as a Wenckebach AV block. How does this occur? Well, let's look at the way I look at it. The parasympathetic postganglionic neurons. You can see that we have the sinus node. It is innervated by the right vagus, and this is due to these postganglionic nerves, the neurons that are lying in the superior vena cava in the right atrium and innervate the sinus node. Whereas on the AV node, it is mainly innervated by the left vagus, and the left atrium and AV groove have these neurons. It is not as simple as that, because there is cross innervation from the right vagus across to the left side, as well as from the left vagus across to the sinus node area. So it's not as simple as all that. But when one looks at the ECGs of young people overnight, you can see why then that the sinus node, when it is innervated by the right vagus and it is stimulated, it causes sinus bradycardia, whereas at the AV node, it causes Wenckebach AV block. And therefore, when both nerves are stimulated, we have a mixture, an amalgam of both of those occurring. Now, on some occasions, even in the young person, we can have syncope. And the syncope may not just occur at night time, but may occur while the patient is driving or any time during the day. And this is quite a serious issue of vagal hypertonia. And as a result of that, we find that cardiac pacing is sometimes suggested as a way of curing this. But remember, there is also vasodilatation, and this is cardioneurosyncope. And as a result of this, there are not always that successful. In more recent times, cardioneuroablation suggested. This is where the electrophysiologist passes catheters, particularly to the sinus node area, if it's profound sinus bradycardia and sinus arrest, and then tries to ablate these postganglionic neuron that actually cause this stimulation. This is a modulation or an ablation, and there has been some success in some centres, but it is not widely used, and maybe we'll hear more of this in the future. So remember, vagal hypertonia is not uncommon. It's in the young. It's generally at night when we see it on Holter monitoring, but it can occur during the daytime and cause quite profound syncope. Thank you.